Fetal lie describes the relationship of the fetal long axis to that of the mother. For fetus in a longitudinal lie, the fetal axis is along the long axis of the maternal abdomen. For fetus in the transverse lie, fetal axis is at the right angle of the maternal axis. In an oblique lie, the position of the fetus is slanting around 45 degrees to the maternal axis. The presenting part is the portion of the fetal body that is either foremost within the birth canal or in closest proximity to it. It can be cephalic, breech, or shoulder. If the head is foremost within the birth canal, it is referred as cephalic presentation. On the other hand, if the breech is foremost in the birth canal, then it is breech presentation. Under cephalic presentation, we have different types. We have the vertex or occiput presentation, face presentation, sinciput presentation, and the brow presentation. In a vertex or occiput presentation, the occiput is presenting. In a face presentation, the fetal face is presenting. In a sinciput presentation, the anterior fontanelle is presenting. In a brow presentation, the fetal brow is presenting. For breech presentation, the bitrochanteric diameter is presenting. We have basically three types of breech presentation. We have frank, complete, and incomplete breech. In frank breech, the thighs are flexed and knees are extended. In complete breech, both the fetal thighs and knees are flexed. In incomplete breech, the thighs are flexed, but only one of the knees are flexed and the other one is extended. Sometimes, the foot prolapses to the birth canal, thus incomplete breech is called footling breech. For shoulder presentation, the shoulder or the acromion is presenting into the pelvic inlet.
Fetal attitude is when the fetus assumes a characteristic posture described as attitude or habitus. The fetus becomes folded upon itself to create a convex back. On the yellow box, the head is sharply flexed, the chin is almost in contact with the chest, and on the blue box, the thighs are flexed over the abdomen and the legs are bent at the knees. Fetal position refers to the relationship of the randomly chosen portion of the fetal presenting part either to the right or left of birth canal. To be able to know the fetal position, we have to identify which is the anterior, posterior, right, and left side. The posterior part will be the sacrum and the anterior part is the symphysis pubis. Imagine the mother is lying supine and you are looking through her pelvis. This will be the maternal right side and the maternal left side. Anything below will be the posterior portion and anything above will be the anterior portion. We have to draw an imaginary cross on the maternal pelvis. In a cephalic presentation, the reference point will be the occiput of the baby. For example, in this position, this will be the occiput anterior. Next, in this position, the occiput is on the maternal left side and still occupies the anterior portion, so this would be the left occiput anterior. In this position, the occiput is still on the left maternal side and occupies the transverse portion, so this would be the left occiput transverse. 2/3 of all the vertex presentations are in the left occiput position and 1/3 of all the vertex presentations are in the right occiput position. Leopold's maneuver is an abdominal examination that determines the position of the baby inside. The mother lies supine and comfortably positioned with her abdomen exposed. The first maneuver, LM1 or the fundal grip, identifies the fetal lie and fetal pole that occupies the fundus, whether it is cephalic or podalic. Breech gives a sensation of large nodular mass and the head feels hard, round, and more mobile. LM2 or lumbar grip identify which side of the mother is the fetal back. The palms are placed on either side of the maternal abdomen and gentle but deep pressure is exerted. The fetal back gives the sensation of hard, resistant structure, and the fetal extremities will have small, irregular, mobile parts. LM3 or Pollick's grip confirms the fetal presentation. The thumb and fingers of one hand grasp the lower portion of the maternal abdomen just above the symphysis pubis. If the presenting part is not engaged, a movable mass will be felt Usually, it is the head. LM4 or pelvic grip. The examiner faces the mother's feet and the fingertips of both hands are positioned on either side of the presenting part. This maneuver determines the degree of descent, and the examiner will exert an inward pressure and then slide caudal along the axis of the pelvic inlet. When the head has descended into the pelvis, the anterior shoulder or the space created by the neck may be differentiated readily from the hard head.
Cardinal movements of labor. Engagement, the mechanism by which the biparietal diameter or the greatest transverse diameter in an occiput presentation passes through the pelvic inlet. Descent, it is brought about by one or more of four forces. First, pressure of the amniotic fluid. Second, direct pressure of the fundus upon the breech with contractions. Third, bearing down efforts of maternal abdominal muscles. And fourth, extension and straightening of the fetal body. Flexion. With this movement, the chin is brought into more intimate contact with the fetal thorax, and the appreciably shorter suboccipitobregmatic diameter is substituted for the longer occipitofrontal diameter. Internal rotation. This movement turns the occiput gradually away from the transverse axis. Usually, the occiput rotates anteriorly toward the symphysis pubis, but less commonly, it may rotate posteriorly toward the hollow of the sacrum. After internal rotation, the sharply flexed head reaches the vulva and undergoes extension. When the head presses on the pelvic floor, however, two forces come into play. The first force, exerted by the uterus, acts more posteriorly, and the second, supplied by the resistant pelvic floor and the symphysis, acts more anteriorly. The resultant vector is in the direction of the vulvar opening, thereby causing head extension. This brings the base of the occiput into direct contact with the inferior margin of the symphysis pubis. External rotation or restitution. It corresponds to rotation of the fetal body and serves to bring its biacromial diameter into relation with the anteroposterior diameter of the pelvic outlet. It brings the presenting part to its original position. Expulsion. Almost immediately after external rotation, the anterior shoulder appears under the symphysis pubis and the perineum soon becomes distended by the posterior shoulder. After the delivery of the shoulders, the rest of the body quickly passes. Quick review.
Good morning, my name is Claire Tiaco and I'm going to demonstrate the midline episiotomy and mediolateral episiotomy. For midline episiotomy, fingers are insinuated between the crowning head and the perineum. The scissors are positioned at 6 o'clock on the vaginal opening and directed posteriorly. Incision length varies from 2 to 3 centimeters depending on perineal length and degree of tissue thinning. With mediolateral episiotomy, scissors are positioned at 7 o'clock or at 5 o'clock, and the incision is extended at 3 to 4 centimeters toward the ipsilateral ischial tuberosity.
Birth canal lacerations. The first degree laceration involved the fourchette, perineal skin, vaginal mucous membrane, but not the underlying fascia and muscles. These included periurethral lacerations. As you can see in the picture, the lacerations are very shallow. You may not repair if it is not bleeding. Second degree lacerations involve in addition to the fascia and muscle of perineal body, but not the anal sphincter. These tears usually extend upward on one or both sides of vagina, forming an irregular triangular injury. As you can see in the picture, there is triangular injury and also involvement of muscles like bulbocavernous muscle and superficial transverse perineal muscles. Third degree lacerations. Lacerations extend farther to involve the anal sphincter. You can see in the picture laceration involving external anal sphincter and rectum remains intact. Fourth degree laceration extend through the rectum mucosa to expose its lumen. In the picture, there is laceration involvement of external anal and internal anal sphincter and also involvement of rectal mucosa.
Hi, good morning. This is Clerk Villusino, and I am going to demonstrate on how to catch a baby during a normal vaginal delivery. So the materials that we are going to need are the sterile gloves and a clean cloth. This is what we are going to use to catch the baby. And this will be draped on one hand and to be positioned in the perineum. So let's say this is the perineum of the mother, and the upper portion is the symphysis pubis. This is the delivery of the occiput anterior position. Let's assume that this is the vulvovaginal opening, which is dilated by the fetal head. When the fetal head is visible, it is called the crowning. And also, when the head distends the vulva and perineum, it also opens the vaginal introitus to about 5 cm or more in diameter. The gloved hand is used to support the perineum, while the other hand is used to guide and control the fetal head to avoid expulsive delivery. So we will assume that the baby is already in their crowning position. The gloved finger beneath the draped towel exert forward pressure on the fetal chin. At the same time, the other hand presses superiorly against the occiput. Subsequently, the mouth will appear over the perineum. After delivery of the head, a finger should be passed across the fetal neck to determine if there is cord coiling. If the umbilical, you have to do it like this while holding the head of the baby with stability. If the umbilical cord is felt, it should be slipped over the head. And immediately after the head has come out, it will fall posteriorly. It will go like this. So that's why it is almost in contact with the paternal anus. So that's the purpose of the drape hand, so that the fetal face will not be in contact with the maternal feces. And then the occiput turns toward one of the maternal thighs. So this is the left thigh and this is the right thigh. And the head assumes a transverse position. This external rotation indicates that the bisacromial diameter, which is this one, this is the transverse diameter of the thorax, has rotated into the antero-posterior diameter of the pelvis. So this is the anterior portion of the mother and this is the posterior. So just after the external rotation, the shoulders will appear, and they are born simultaneously. The sides of the head are grasped with hands, and gentle downward traction is applied until anterior shoulder, this one, appears under the pubic arc. Next, by an upward movement, the posterior shoulder, which is the other one, is also delivered. The rest of the body almost always follows the shoulders without difficulty. Immediately dry the baby and place them on the mother's chest or abdomen in a prone position.
The first time-bound intervention would be immediate drying, and using a dry, clean cloth, dry the newborn's face, the eyes, the front, the back, the arms, and the legs. Now this will prevent hypothermia and stimulate breathing. The next part would be immediate skin-to-skin contact of the newborn with the mother. Place the newborn on a prone position towards the mother's abdomen. Cover the baby's back with a blanket, head with a bonnet, and place an identification card or band on its ankle, and this will prevent infection, hypothermia, and hypoglycemia. Now the third step will be to properly clamp and cut the cord. Now this is done once the pulsation has stopped, and this usually happens 1 to 3 minutes after. Now when the pulsation has stopped, place a cord clamp 2 cm above the umbilicus and another one at 5 cm above the umbilicus. And cut in between, making sure that you're using a sterile instrument. Once the cord clamping is done and cutting is done, make sure that you inject 10 IU of oxytocin to the mother via intramuscularly. Now this prevents anemia and brain hemorrhage, especially in premature newborns. The last step would be the non-separation of the baby from the mother and the initiation of breastfeeding. This is done by observing the newborn, and when the newborn shows feeding cues such as opening the mouth and breathing, the mother can be encouraged to move the newborn towards the breast. Mother can also be advised on proper positioning and attachment.